Welcome back, guys. This is part B of 2021 ACR's Guideline for the Management of ANCA-associated vasculitis, which will cover recommendations regarding EGPA. A bit of festive background I know I'm using here because all these circles remind me of eosinophils, and hopefully it'll help you remember the topic of our talk. EGPA will present in many different ways, but some of the key features will include asthma, allergic rhinitis, eosinophilia, which can be seen in either the tissue or in the blood, and vasculitis. One disclaimer for the following recommendations, by the way, there aren't too many randomized controlled trials for EGPA. Therefore, the recommendations here are derived from lower quality and indirect evidence in addition to expert opinions. So without further ado, let's get started. First, we have 3 recommendations for active and severe disease. Number 1, glucocorticoids during induction can be via IV or PO route, but remember to add non-glucocorticoid immunosuppression. Number 2, you'll be inducing with cyclophosphamide or rituximab. In the past, cyclophosphamide has been used more commonly, although there's an increased experience with rituximab now, and more patients are on it nowadays. When thinking about which agent to give, you may factor in following features. Cyclophosphamide can be considered if A, active cardiac involvement, B, ANCA is negative, and C, there is severe neurologic or gastrointestinal symptoms. Rituximab, on the other hand, may be a better option if A, there's active GN, B, ANCA status is positive, and C, those who received prior cyclophosphamide exposure or those at risk for gonadal toxicity. Number 3, choose cyclophosphamide or rituximab over mepolizumab. Mepolizumab's efficacy is not established in severe active EGPA. Next, let's talk about active but non-severe EGPA disease. Guidelines give examples like asthma, sinus disease, or non-severe vasculitis to define non-severe EGPA. So number 1, mepolizumab with glucocorticoids is better than using methotrexate, Imiran, or Cellcept with glucocorticoid. Mepolizumab, which is an IL-5 inhibitor, has been found to be efficacious for non-severe forms of EGPA in a randomized controlled trial. Although patients with non-severe vasculitic manifestations were represented in this trial, questions still remain about the effectiveness of mepolizumab for all aspects of non-severe vasculitis. Individual factors need to guide therapy, of course, and sometimes using methotrexate, Imiran, or Cellcept may make more sense. There's insufficient data to support one over the others between methotrexate, Imiran, or Cellcept. Number 2, use methotrexate, Imiran, or Cellcept with glucocorticoid rather than glucocorticoid alone in order to minimize steroid toxicity. Glucocorticoid monotherapy may be appropriate if patient has mild asthma or allergic symptoms or if patient is pregnant. Okay, so continuing with active but non-severe disease. Number 3, choose methotrexate, Imiran, or Cellcept with glucocorticoid over rituximab or cyclophosphamide with glucocorticoid. Why? First, there's more experience in EGPA with these medications compared to rituximab. Second, why not cyclophosphamide? The general idea is to avoid cyclophosphamide if there are no severe manifestations because of the toxicity. In case where methotrexate, Imiran, or Cellcept may be ineffective or there's non-severe vasculitis with positive ANCA, guidelines suggest possibly using rituximab in those cases. Here, in some series, mononeuritis multiplex was included as non-severe vasculitis. C. Let's talk about remission. Number 1, in the scenario where a patient with severe EGPA was induced with cyclophosphamide and went into remission, choose methotrexate, Imiran, or Cellcept over rituximab because there's less experience for remission maintenance with rituximab. Rituximab can be considered if remission were induced with rituximab or if there are contraindications to methotrexate, Imiran, or Cellcept. Number 2, in the case where a patient has entered remission after a severe disease, choose methotrexate, Imiran, or Cellcept over mepolizumab. Mepolizumab's primary experience is for refractory, non-severe disease, and it is difficult to extrapolate its efficacy as a maintenance agent. Number 3, how long should you continue glucocorticoid? It is based on each individual circumstances, but guidelines suggest to use minimum effective dose to minimize toxicity. D. How about relapse with a severe disease? Number 1. This scenario is for people who were induced with cyclophosphamide for severe disease who went into remission but now are relapsing with another episode of severe disease. In such a situation, using rituximab over cyclophosphamide is recommended. The general idea is to avoid retreatment with cyclophosphamide if possible due to toxicity. Cyclophosphamide may be considered if there's recurrent cardiac involvement. Number 2, how about exact same scenario as number 1, but patient who had been induced with rituximab? In that case, you still give rituximab over cyclophosphamide, but cyclophosphamide can be considered if A. Last rituximab was too recent, or B. Patient has cardiac involvement. How about relapse with a non-severe disease? Number 1, if patient is on methotrexate, Amarin, or Cellcept, add mepolizumab to the current treatment rather than switching to another agent. Number 2, patient is on low-dose glucocorticoid alone and relapses with a non-severe disease. What do you do in that situation? Here you can add mepolizumab rather than adding methotrexate, Amarin, or Cellcept. Number 3, EGPA patient with relapse with non-severe disease and elevated IgE level should get mepolizumab rather than omalizumab because omalizumab's role in EGPA is limited. So an example of this would be something like, let's say a patient who is currently on methotrexate, Amarin, or Cellcept, the patient presents with a relapse with asthma or sinonasal disease. Patient is found to have elevated IgE level. So in this case, rather than giving omalizumab, which is an anti-IgE antibodies, guidelines suggest giving mepolizumab, which is an IL-5 inhibitor. Next, we have other considerations or recommendations. Number 1, regarding use of leukotriene inhibitors. A. You can continue the leukotriene inhibitors in patients who get the new diagnosis of EGPA, and B. Leukotriene inhibitors can be started in patients who have EGPA. Following the introduction of leukotriene inhibitors, concerns were raised about a link between using leukotriene inhibitors, for example, montelukast or singular type of medication, and developing EGPA. But the causal relationship has not been confirmed. The guideline, however, notes that leukotriene inhibitors are not to be used to treat symptoms aside from asthma and sinonasal disease. Number 2, if a patient has a new diagnosis of EGPA, get an echocardiogram as cardiac involvement is a major cause of disease-related mortality in EGPA. Number 3, use 5-factor score. FFS is a prognostic tool used for patients with EGPA. In 1996, a cohort of 342 patients with PAN or EGPA were studied, and the following factors were used to predict outcomes of the patients. Proteinuria of greater than 1 gram per day, renal insufficiency with creatinine greater than 1.58 milligrams per deciliter, GI involvement, cardiomyopathy, or CNS involvement. So you're looking at organ system involvement that makes EGPA severe disease. Top to bottom, there's CNS, heart, GI, kidneys. Additional factors such as ear, nose, and throat parameters and age greater than 65 were added to the 2011 version. However, 1996 version is still more commonly being used. It's a tool to help clinicians make treatment decisions. The higher the number, the worse the outcome you can expect. Applicability to newer therapies is unknown. Okay, going back to other consideration. Number 4, sinonasal involvement may mean needing to involve laryngologists to seek topical treatment or nasal rinses. Number 5, if patient is on cyclophosphamide or rituximab, there's a conditional recommendation for PJP prophylaxis, and the same considerations for GPA/MPA can be applied to those with EGPA. Here are some finishing thoughts. What I cover in this talk and last video is a guideline, which literally means a helpful tool clinicians can use for making appropriate management decisions. No guideline, however, is absolutely correct for all patients, so please factor in the patient's clinical condition, preferences, and values in making treatment decisions. Limitations exist with any guideline, but this one particularly, the evidence is not strong, as noted by the writers of the guideline. They actually warn these recommendations not be used to restrict access to treatment or require that certain treatment be used before others. And they note that alternative treatment may be reasonable. Another thing is that voting panel on this guideline was made up mostly by rheumatologists. But as you know, ANCA-associated vasculitis are a multi-system disease, and you'll most likely be working together with other subspecialists like nephrologists, pulmonologists, or laryngologists, and possibly cardiologists. Other subspecialists may favor a different management strategy, so the guideline encourages rheumatologists to discuss treatment plans and coordinate care with other subspecialists as needed. Last thing is about ivacibin, which is a C5a inhibitor, which has not been included in this current guideline. The study on the drug was published after the completion of the last literature search for this current guideline, so we can look forward to the discussion regarding the medication and the future updates to this guideline. Thank you for your attention, and be sure to check out the actual guideline yourself, as there are some diagrams and treatment flow charts. I did not include in my slides, but they will be very helpful to you. Good luck studying, and see you next time.